Hi, I'm Dr. Marty Weiser. I am a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center. My interest and expertise is in intestinal cancers, including colon, rectum, small bowel, and appendix. Which rectal cancer patients are eligible for surveillance without surgery? This is also referred to as non-operative management or watch and wait, or sometimes rectal or organ preservation. It asks the question, can surgery be avoided in some patients receiving neoadjuvant therapy, almost like an anal cancer approach? The driver for this is that rectal cancer surgery affects bowel function and quality of life, and some patients require colostomy. Can we identify those patients very likely to have a complete pathologic response following surgery? Does clinical response predict pathologic response? And what are the features of a complete clinical response? How do we follow these patients? And what's the protocol if tumor regrows? We use the term regrowth rather than recurrence to differentiate those patients in which tumor regrows after observation versus recur after surgical resection. The clinical scenario is something like this. You see your patient in the office following rectal cancer surgery, and you tell them that there's very good news. The pathologic specimen reveals no evidence of disease or a complete pathologic response, and their overall survival and disease-free survival are excellent. Most patients are happy, but some wonder, did they need to have their rectum removed? Do they need to have a colostomy? Over the past 2 decades, this occurred in about 10 to 15% of patients in the office. And this was at a time when practice generally included the use of chemoradiation with immediate surgery, followed by adjuvant chemotherapy. Even though it was rare, this was still a frustrating problem for many people. Noted Brazilian surgeon Dr. Habergama brought watch and wait to the general attention of clinicians. She performed an observational study and reported it in 2004 at an international meeting. Patients were observed if they had a complete clinical response at 1 year, and she described disease-free survival and overall survival in patients with a complete clinical response and a complete pathologic response, and noted that the outcomes were the same. And this told us that complete clinical responders could be observed. Although it seems obvious now, it wasn't in 2004. And this was greeted with significant skepticism when it was presented in 2004 at the international meeting. Fast forward to 2021, watch and wait or non-operative management has become mainstream. But there's many details to be clarified. Again, what constitutes a complete clinical response? How do you observe these people? How do you adjudicate discrepancy between imaging and physical exam, including proctoscopy? And what do you do if the tumor regrows? Now, although Habergama brought the concept to general attention, the idea of non-operative management wasn't new. In a 1995 publication from the Princess Margaret Hospital, 229 patients were described with rectal cancer that either had unresectable tumors, patients were medically unfit, or refused surgery. 65 of these patients had a complete clinical response, and 29 of them had regrowth over time. And there were some long-term survivors. Memorial Sloan Kettering Cancer Center reported their experience with non-operative management in 2009. It's a series that includes patients treated from 2006 to 2016. And during that time, non-operative management was just starting to be used, and it was used very selectively. In a cohort of 1,070 patients, 113 had a complete clinical response and chose non-operative management. There were 22 regrowths, or a 20% regrowth rate. And this number will come up again and again, as many studies have shown a 20 to 25% regrowth rate with non-operative management. 75% of the regrowths occurred within 1 year, and 90% of the regrowths occurred within 2 years after completion of neoadjuvant treatment. And this is the time of course, most intense surveillance. The regrowths were salvageable, and disease-free survival, distant metastases-free survival, and overall survival seemed reasonable. There was an 8% crude distant metastases rate in the entire group of non-operative patients. Around the same time, an international registry of non-operative management published their results. 47 institutions in 15 countries, there were 880 complete responders that were followed. Now, it's a limited study because follow-up protocols were not standardized, imaging was not standardized, and therefore the data is not very granular. However, with a median follow-up time of over 3 years, the 2-year cumulative incidence of local regrowth was 25%. Again, that same number coming up again and again. 88% of all regrowths were diagnosed within 2 years following completion of neoadjuvant treatment, and 97% of the regrowths involved the bowel wall and could be observed with imaging or with proctoscopy. And they also had an 8% distant metastases rate in the entire non-operative cohort. So what are the keys to non-operative management? One is time, and the second is the concept of total neoadjuvant therapy. The last key to developing a non-operative program is to have a protocol with set follow-up schedule, imaging, examination, including proctoscopy, and then this standardized nomenclature, including complete, incomplete, and near complete response. Well, the first idea is response over time. We know that tumors respond following radiation over time, and in a report of over 300 patients treated from 1997 to 2007, the response started to plateau at 12 weeks. Again, it's not surprising pulling knowledge from anal cancer patients. However, there's always been a concern that delaying surgery after radiation could complicate rectal resection because of radiation-induced fibrosis. And this was the topic of the timing of rectal cancer response to chemoradiation trial, a phase 2 multi-institutional non-randomized trial looking at tumor response following chemoradiation over time, published in 2015. Surgery was delayed after radiation up to 20 weeks. FOLFOX chemotherapy was delivered in the waiting period. So some patients had no FOLFOX, they had chemoradiation and went to surgery at 6 weeks, while others had up to 6 cycles of FOLFOX and surgery was delayed 20 weeks. The results showed that there was no increase in technical difficulty of the surgery, intraoperative or postoperative complication, and therefore waiting after pelvic chemoradiation is safe. Complete response rates went from 18% in the patients that had surgery directly after chemoradiation to 38% when surgery was delayed 20 weeks. Of course, the results are confounded by the fact that both time and chemotherapy were altered, so we're not sure what the most important factor is, although many believe that time is the most important factor. So this does support the premise that surgery can be delayed and is associated with increased response. Now, the second important concept for non-operative management is total neoadjuvant therapy, the concept that all chemotherapy and radiation is delivered before evaluation for surgery or watch and wait. Surgery evaluation, therefore, is the last step. And multiple studies have demonstrated that TNT is associated with better tolerance of oxaliplatinum and 5-FU chemotherapy, less toxicity, greater proportion of patients receiving a prescribed dose. Memorial Sloan Kettering Cancer Center published a retrospective review in 2018 comparing standard treatment to TNT. 310 patients were treated along the standard line with chemoradiation followed by surgery at 6 weeks and then adjuvant FOLFOX chemotherapy, and 410 patients had total neoadjuvant therapy. generally with induction FOLFOX chemotherapy followed by chemoradiation and then surgery. Complete response rates were 38% in the TNT group compared to 20% in the standard group. Interesting, in the stage 2 rectal cancer patients, complete response rates were over 50% in the TNT group. Most recently at ASCO 2020, the OPRA trial was reported. This is a phase 2 trial comparing non-operative management in 2 TNT regimens. Chemoradiation with consolidation FOLFOX-CAPOX compared to induction FOLFOX-CAPOX followed by chemoradiation. So a sequencing question. The complete response rate or non-operative management in the entire group was over 50%, with a higher complete response rate in the chemoradiation with consolidation FOLFOX-CAPOX arm. However, again, this is a bit confounded by the fact that the time to surgery was longer generally if you from radiation if you got the radiation before the chemotherapy. The manuscript and details are pending, so we'll have to wait to see exactly what the difference is. Well, what about short course radiation? Short course radiation and delayed surgery has not been as extensively studied as chemoradiation. The Stockholm 3 trial did show us that delay following short course radiation is associated with increased tumor response. And the Rapido trial, again recently reported in ASCO 2020, demonstrated increased response with short course radiation followed by consolidation FOLFOX-CAPOX, although non-operative management wasn't specifically addressed in this study. Likely short course radiation in a TNT program will be effective with non-operative management, but it's unknown if short course radiation or chemoradiation is better. So what are the nuts and bolts of non-operative management? We talked about the use of total neoadjuvant therapy and about waiting longer following the completion of neoadjuvant treatment for evaluation of non-operative management. Assessment of response includes clinical exam with digital rectal exam, proctoscopy, and imaging with MRI. We classify patients as having a complete response, an incomplete response, or something in between called a near complete response. The complete responders have a smooth tumor or residual tumor on digital exam. Endoscopy shows a flat white scar with telangiectasias, and MRI shows a dark T2 signal with no restricted diffusion. Incomplete responders have a palpable tumor on digital exam. Proctoscopy reveals nodules, maybe even some ulceration. MRI shows an intermediate T2 signal with clear restricted diffusion. Now, the near complete responders, those are people that you may watch a little bit further. On digital examination, they have slight induration. Proctoscopy shows a bit of nodularity, some mild irregular scar. And the MRI shows a mostly dark T2 signal with minimal restricted diffusion. So following total neoadjuvant therapy, we generally assess patients at 6 weeks following completion of treatment, with proctoscopy in the office and MRI at 3 months. The decision for surgery is generally made at that 3-month mark, but there are exceptions. Those near complete responders that you've been following over time, where on proctoscopy, the scar is getting more and more flat and becoming white, pale with telangiectasias. You may wait a little bit longer on those people. Once you're deemed to have a complete clinical response, the most intense surveillance is the first 2 years, since 85 to 90% of regrowths occur in that time. Generally, physical exam with digital rectal examination and proctoscopy is performed every 3 to 4 months, MRI every 6 months. After 2 years, when the risk of regrowth goes down significantly, patients are seen in the office with proctoscopy every 6 months and MRI is performed every 6 to 12 months. the usual CEA and CT and follow-up or surveillance colonoscopy is performed as usual. I'm often asked, what's the role of biopsy? We don't routinely use biopsy as it's unreliable, with one study showing a negative predictive value of 21%. The high false negative rate gives patients a false sense of security. We really don't know if there's a complete response, and patients have to be observed over time. A single biopsy doesn't really help us. The decision to go to surgery is based on clinical exam with the help of MRI, and you don't need a biopsy to proceed to surgery. However, I have to admit there are patients that will not agree to surgery unless a biopsy is performed showing disease. Well, what happens when you identify a regrowth? Repeat staging, CT scan of the chest, abdomen, and pelvis with oral and IV contrast, colonoscopy if the initial diagnostic scope was greater than a year, and then you proceed directly to surgery. Lastly, the key is to treat patient expectation. From the initial consultation and to all follow-up visits during treatment, I discuss non-operative management in interested patients. I review the 30 to 40% chance of complete clinical response. This doesn't include the recent Oprah data. And a 20 to 25% chance of regrowth requiring surgery. And I don't bring up biopsy unless they want to talk about it, and I discuss the limited role of biopsy. There is uncertainty that can lead to patient anxiety, and some patients prefer standard approach with surgery following neoadjuvant therapy, and I never talk a patient out of surgery.
Thank you for watching. Since this interview, new information has been released. And now we go to the update.
There were significant updates in neoadjuvant therapy for rectal cancer at ASCO 2022. Most notable was the late-breaking report by Dr. Cirsik from Memorial Sloan Kettering on 18 patients with MMR-deficient rectal cancer. The trial was a single-arm study in which patients with stage 2 or stage 3 MMR-deficient rectal cancer were treated with the PD-1 inhibitor dostarlimab as a single agent every 3 weeks for 6 months. The trial was designed to enroll 30 patients, but a report of the first 18 patients who were enrolled, 17 of whom presented with node-positive disease, showed a 100% response rate, with 14 out of 14 of the patients who had reached 6 months of treatment achieving a complete clinical response. Notably, thus far, none of the patients have required chemotherapy, radiation, or surgery. All of them will be followed very closely for local recurrence and distant recurrence, but thus far no recurrences have occurred, with the longest patient being followed up to 24 months. While there is no doubt that more patients are needed to be enrolled and longer follow-up is required, this study could potentially be immediately practice-changing, particularly because it's going to be very highly unlikely that any randomized trial for this patient population will ever be done for ethical reasons. As an update for the treatment of MMR-proficient rectal cancer, Tamberi et al. Presented their phase 2 trial of capecitabine and radiation, followed by the PD-L1 inhibitor durvalumab as perioperative therapy for rectal cancer. This was called the Pandora trial. In this study, patients with stage 2 or stage 3 rectal cancer were treated with standard chemoradiation, which is standard capecitabine 825 milligrams per meter squared twice a day, and in this case, 50.4 gray of radiation over 5 weeks, then followed by durvalumab every 3 weeks for 3 total doses. All patients then went on to have surgery. Out of 55 evaluable patients, 78% of whom had node-positive disease, the complete clinical response rate was 11%, and the complete pathological response, as determined after surgery, was 35%. Importantly, MMR status was not yet reported as part of this study and actually could have a major impact on the analysis because if a percentage of these patients were MMR deficient, that could really color the overall complete clinical and pathological responses. Additionally, one has to consider that in the NRG GI-002 trial reported by Rama et al. Of FOLFOX followed by chemoradiation with or without pembrolizumab, the path CR rate in the non-pembro arm was still 29%. So it's really unclear if the immunotherapeutic agent is actually adding anything to the path CR rate in this patient population. Finally, Jensen et al. Presented their late-breaking abstract of chemoradiation for patients with low rectal cancers within 6 centimeters of the anal verge. Patients also received capecitabine 825 milligrams per meter squared twice a day, plus 62 grays, so a higher radiation dose over 5 weeks. 107 patients were enrolled, and while this was specifically a low rectal cancer population, the rate of node-positive disease was only 29%. 86% of patients achieved a complete clinical response and were managed with close observation. For the 103 patients followed closely for 2 years, 59% had ongoing no evidence of local or distant recurrent disease, and the 30-month overall survival rate was 95%. These are all very positive results. However, 23 patients did have local recurrence requiring some form of surgery, and the 30-month metastasis-free survival rate was only 85%. Overall, of these 3 trial updates, only the dostarlimab trial was potentially practice-changing. The developmab trial was intriguing, but the actual benefit of the addition of immunotherapy remains to be proven in an MMR proficient patient group. And while the Danish 2 trial, the Jensen trial, added to the notion that non-operative management of rectal cancer is a legitimate consideration, questions still remain on which patients and which specific regimens are the best to follow for this treatment paradigm.